All right, welcome everyone. We will get started here in just a moment, just letting people filter in from the waiting room. Really happy to have you all here with us today. All right, well, we'll go ahead and dive right in. So thank you everyone for joining us today. I'm really excited to be here again with Margo. This, I think, is our fourth year in a row. So back by popular demand, Margo and her team are incredible resources for everything Medicare and ACA related. And I know we're in for a really special presentation today. I will go ahead and just toss it over to you, Margo, to go ahead and just dive in.
Awesome. Thank you, Lauren. And thank you all for showing up today. Hopefully you have coffee or wine. You know, it's almost noon, so it's never too early. But today we're going to jump into all things Medicare, a brief recap of my services if you are not familiar with my team here over at Steinlage Insurance. We offer free services if you need guidance on Medicare or ACA. You know, you're an early retiree, or maybe you're moving into Medicare and it's impacting your younger spouse or younger children's health insurance. We look at the entire family dynamic when that transition needs to unfold. And I highly recommend starting this process, 3 to 18 months out from your transition date. It's never too early, so that you have a full understanding of, what your timeline is to get that transition into ACA, Marketplace, Covered California, or Medicare. We want to make sure we're lining everything up accurately and creating that timeline and strategy well in advance of your actual transition. And once you are ready to make that move, we've kind of created your strategy and helped you figure out a game plan for the whole family. We are also there to support you throughout the entire enrollment process. So if you need, Medicare support or enrollment support, we're also there for the back end if you need any billing support or a new card. So that pre-enrollment strategy and post-enrollment strategy and the actual enrollment is where our team really shines. So any questions you guys have around Medicare or ACA, feel free to steer them my way or through Lauren. They'll just point you over to us to help out here. We are in all 50 states. I was just out in California for the big FPA NorCal Financial Advisor Association event, and I saw Lauren. I got to eat lunch with her. So we have a ton of clients in California, but our reach is national. I do have clients in Alaska and Hawaii. As I said at the NorCal event, I was like, man, I'm really waiting for that policy delivery to happen in Hawaii so I can get a ride off. So we follow you because we have a lot of clients, who start on the East Coast and they venture down into Florida, or they are lucky to reside in California their entire lives. Lucky you guys. So today we're going to jump in and really go over the nuts and bolts of Medicare and give you and arm you with information and education. We're going to cover who is eligible for Medicare, what are the rules, what is required at 65, what's not. Many of you will work beyond age 65, and you are the exception to the rule around Medicare at 65. And then we're going to look at the different moving parts of Medicare. What is a supplement, also known as a Medigap plan? How does it work with Medicare? How does Part D? What are changes happening to Part D? What is Medicare Advantage Part C that we constantly see on TV? And then lastly, we're going to look at changes in Medicare as a whole. We'll go over IRMA if you're a high earning individual, with which most of my clients are. We'll talk about appealing IRMA, make you aware of IRMA. No, Medicare is not free. And then we'll look at changes for 26 and 27 and just the lay of the land that you can anticipate as you make these transitions over the next few years into Medicare. And then lastly, I want to add in, instead of here, ACA Outlook, I'm going to add in the newest program under Medicare that was just released this month for a July 1st kind of kickoff. It's called the GLP-1 Bridge. I feel like everything these days is about GLP-1. Well, shocker, Medicare has started a new program for those of you on GLP-1 for weight loss specific reasons. We'll talk about that program, the pros and cons to it, and things to watch out for.
And
Okay.
one thing if I can just jump in real quick, Margo, I did send a chat, but feel free in the chat or the Q&A, ask questions anytime. If they're tied to that slide, I'll jump in and ask Margo in the moment, or we can come back to them at the end. Or if they're really specific and personal, we may just reach out separately after the fact to get your specific situation. And we are recording this session, so it will be available to view at a later date if you need to come back, or if there's anyone you know who might be interested. So thank you.
Awesome. So who is eligible for Medicare? So the general rule here is that if you are turning 65, you're either automatically enrolled at 65 into Medicare if you're collecting Social Security. So if you're 63, 64, you turn on Social Security, you're collecting. Well, at 65, the first of your birth month, you're automatically enrolled in Medicare and you have a red, white, and blue card. If you're not collecting Social Security, Medicare is an opt-in program and you have to opt in or enroll in Medicare so that Medicare begins essentially on the first of your birth month. So my birthday, everybody and their mother is going to know my birthday. I hope I get lots of birthday cards soon. June 29th is coming up. I'm almost 38. But June 29th is my birthday. I could start my Medicare enrollment if I was not collecting Social Security in March, April, or May for a June 1st effective date. If I'm a little slow to the game and I forget I'm traveling, oops, I do have to do something for Medicare. If I submit my Medicare application in June, I would get a July 1st effective date. I could have a gap in my health insurance. If I'm really late to the game, I really missed the boat, I have 3 months, July, August, and September to enroll for a first of the following month. Again, the issue there can be gaps in health insurance penalties if you're on an ACA covered California plan, getting any subsidy, or a gap in your small employer plan if you're not actively turning on Medicare for the first of your birth month. So for most of us, we have to turn on Medicare, whether it's automatically because you're collecting Social Security or proactively because you're not collecting Social Security. You have to go to ssa.gov and enroll. Everybody has to do something something at 65, unless you or your spouse plan to work beyond age 65 and you have access through a large employer's group health plan. So red flags to watch out for here. It has to be through either your employer or your spouse's employer, and you have to be actively working. It can't be COBRA. So if you're on a large employer group health plan and it's COBRA because you retired 12 months ago, you have to sign up for Medicare at 65. COBRA is not the primary payer. If you are working with a large employer, or your spouse is, and you are enrolled in that employer's large group health plan, then Medicare is optional at age 65. So you can choose to enroll in Medicare, or you can decline Medicare if you're automatically enrolled because you're collecting Social Security. It's an optional program. You can decline, delay Medicare, and stay on that large employer plan for the foreseeable future. And now, when you're ready to come off that large employer plan, at let's say age 69, or your spouse is going to retire at 70, and both of you are getting kicked off the large employer plan, we create this special enrollment period to move into Medicare Part A and or B without any penalties. We also create a special enrollment period for your supplement, your drug plan, or your Advantage plan, whatever route you want to go. So you get this moment to say, do I want Medicare, or do I want to stay on my large employer plan? And large employer plan means 20 or more full or part-time employees. So if you're working for Boeing or Steinlage Insurance, we have close to 30 employees. My team can stay on our group plan and not move into Medicare. And what's really cool here is Medicare has built what's called a Medicare secondary payer rule and legislation that restricts the large employer from forcing you over to Medicare. So they can't discriminate you and carve you off that group health plan because of your age, which is nice because many of you will opt to stay on that large employer plan because maybe you have a younger spouse or children. They don't want to go over to the marketplace. Or maybe there's an HSA, health savings account, that you want to max out for the whole family, which is close to $10,000 worth of tax benefit. So here, many of you will stay on that large employer plan, max out the HSA, and delay Medicare, and then at a later date, opt into Medicare under that special enrollment period. That happens frequently. So about 50% of my conversations, myself and my team, we're saying, you don't need us yet. Stay on that large employer plan. The other half, it's either Medicare is required because you're on a small group health plan, fewer than 20 employees, and they're requiring Medicare to be the primary payer. You're on an ACA marketplace, covered California or Virginia marketplace plan, and you have to move into Medicare at 65. Or you're on a retiree, you're on COBRA, or you're uninsured in some capacity. You have to move into Medicare at 65. So one thing to watch out for, if you are on that large employer plan and you're telling me and my team, hey, it makes most sense to stay on the large employer plan. If you have an HSA, I don't care, and Medicare doesn't care if it's a flex, an FSA, flex spending account. What we are looking for is anyone who is contributing into a health savings account, HSA. If you enroll in the free Part A hospital benefit and delay that premium Part B benefit of Medicare, you can't contribute into your HSA if you opt into that free Part A hospital benefit. So here, what I recommend for many who want to contribute into their HSA is delay both the free Part A and the Part B portion. And now when you're ready to retire, we're triggering Part A and Part B. The second red flag or hurdle to watch out for is when you are ready to come off that large employer plan and move into Medicare, and we sign you up, we submit the paperwork for Part A and Part B at age 69, there will be a 6-month retroactive look back on the Part A free hospital benefit. And we have to time those HSA contributions based on that 6-month retroactive look back from the month prior to paperwork submission. I'm fully in the weeds right now, hunting and gathering, but I see this HSA issue surface almost daily because HR will tell employees, you have to sign up for Medicare Part A. Well, you don't. The only reason you would have to is if you're collecting Social Security. You can't decline Part A if you're collecting Social Security. Those two are married. You can sign up for Part A and not collect Social Security, but if you're collecting Social Security, you can't decline Part A. Okay, so takeaway here, Medicare is optional if you or your spouse are working with a large employer and you're on that group health plan through active employment. Medicare is optional. Everybody else is going to have to sign up for Medicare for the most part at age 65 to avoid penalties and gaps. Okay, and then we start looking at what is Medicare? What do I have to sign up for? How does it work? How do all the pieces of the puzzle fit together? So here, once you tell me, hey, Margo, I have to move Medicare, or I'm telling you, you have to move Medicare and enroll in Part A and Part B, those are the two pieces of original Medicare. So when you're walking around with your red, white, and blue card, it'll say Part A hospital benefit and Part B medical benefit. Okay, once you have that card and you're fully in Medicare and you go walk into the hospital with your red, white, and blue card and you show that medical card, Medicare will cover most of the hospital claim. You'll be expected to pay the first $1,700 hospital deductible each 60-day hospital occurrence. You'll also be responsible for the first $283 medical deductible. So if you walk into the doctor's office, you get your colonoscopy, that's a preventative service. It's free, but there's polyps. They remove polyps. That will be a charge under Medicare. Okay, you'll be the responsible party for the first 283, and then Medicare covers 80% of that. Next week, you go in for an MRI, you need physical therapy for 6 months, and then you need an outpatient surgery. You've satisfied your $283 medical deductible, but you're paying 20% coinsurance on all of those medical claims. Medicare's only covering 80%. So there's no gap on your 20% exposure under Medicare, okay? You'll also see here that the red, white, and blue card does not include drugs, prescriptions. All right, you have to add a Part D benefit in some capacity to have drug coverage. You'll also need to add kind of an a la carte dental and vision. So Medicare doesn't cover all of the claims. There's gaps in the original red, white, and blue Medicare. And all of these ancillary products that you hear about on TV fill those gaps of original Medicare. So when you're ready to enroll, you're enrolling in Part A hospital. And for most of us, that has a zero premium attached to it because you or your spouse or ex-spouse or deceased late spouse, one of you has worked 40 quarters or more throughout your lifetime and funded Social Security, funded the program, and now you get to reap this zero premium hospital benefit. Part B has a standard premium for everybody. It's $202 and change for 2026. And this is adjusted each year by Medicare. So on average, we see it increase by about 5% per year. Medicare Part B premium, that $202.90, is adjusted based on your income. So if you are qualifying for Medicaid, Medicaid in some instances will come in and pay that $202.90 for you. If you are a high earning individual, which means you as a single tax filer makes $109,000 in modified AGI, or as a joint filing couple, you guys are making $218,000 or more in modified AGI, then Medicare will stick an IRMA, income related monthly adjusted amount. It's a mouthful, just call it IRMA. You'll see an IRMA surcharge slapped on that $202.90 per month per spouse, per person on Medicare. So this is where the shock is for many clients, because most of us think, oh, Medicare's cheap. I paid the system. I get it now for cheap, $200, awesome. Well, if you're that high earner, Medicare can cost upwards of $700 a month per person if you're making above $750,000 in modified AGI as a joint couple, filing couple. So I'll talk about IRMA in further detail, but I just want to plant the seed now because as we have these initial discussions with you, we are asking for modified AGI to isolate this Medicare Part B premium. Are you exposed to IRMA? Are you working with a large employer? Is Medicare required? If you're on a small employer plan with plans to continue working for the foreseeable future, you have to go into Medicare. You can't appeal IRMA because you have a high income. You know, Medicare is going to cost you $1,000 with a supplement and a drug plan, and that's expensive. That's, you know, twice as much as you're currently paying with your group, your small group plan. So we isolate and we collect this information so we can have a very detailed consultation with you and lay out strategy and options based on your income, your work plans, and your current insurance.
And Margo, we had a good question come in here on the ages and what you were talking about on the slide before. What if someone is on a large employer health plan, past 65, they stay on the plan and they get laid off, and their hope is to go back to work for another large employer, but there's a break there where between layoff and getting a new job, are they forced onto Medicare at that point if they're over 65?
So a few things. Medicare has a 8-month window that allows you to get into Medicare Part B and Part A, specifically the Part B, with no penalties, no late enrollment. So if you're terminated and, oh my gosh, I got to get scramble and get Medicare for July 1 and I don't do it, you have an 8-month grace window to actually get into Medicare with no late enrollment penalty. So that's one factor to consider, no penalty in that 8-month window. The second thing to watch out for is most COBRA. At that point, you're terminated. You've probably triggered COBRA in some capacity. Most COBRA and carriers, when they float over to COBRA, will say, we are not the primary payer. You need to enroll in Medicare Medicare becomes the primary payer. So what we have seen numerous times over the years is somebody will wait and use that 8-month period, grace period, to avoid late enrollment. And then all of a sudden, they're only rolling around with COBRA. They haven't got that primary piece put in force. And they go into the hospital with, 6 weeks of claims. And now COBRA is saying, we are not paying these claims because you should be filing this all under Medicare. You should have picked up Medicare. So there can be a huge coordination of care issue and payment issue if you wait and use that 8-month window. So the first step I would say is go contact your carrier and the broker who is managing that group carrier, that group product, and ask them, do you require Medicare to be the primary payer once I go COBRA? And if the answer, do you pay anything as primary payer, any portion? And if the answer is no, then you need to giddy up and get on Medicare, and you can select Medicare. If you're terminated in June, you can submit paperwork right now for a June 1st effective date. Or you can tell Medicare, I want a July 1. But if you're being told, no, you don't have primary COBRA coverage, we're going to be the secondary payer, you need Medicare, then you need to get Medicare June 1. So you don't have this gap. Now, to complete that answer, once you find another job and they are offering you group coverage and it's a large employer, you can terminate Medicare Part B, okay, and get out of the premium portion of Medicare and go on that group plan again, okay? So it usually will have a 2-month delay. If I submitted my Part B termination request this month to go on group coverage on large employer plan, go back to work for a large employer, my termination wouldn't take effect until August 1. So I would have to pay 2 months, June and July, of Medicare premiums. So again, these are just kind of the details we will give you in consultations. We do, as Lauren knows, we do a ton of free work, which is not always fun, but hey, we get referrals. So, okay, great question. Keep them coming. So there are gaps in Medicare, and yes, you will pay for Medicare. And some of you, we can't appeal to IRMA because you're going to have great income, passive income into the retirement years. Great job, Lauren, and great job to you as workers and making great money. But for some of you, we can appeal IRMA, and we can save you a couple of grand in IRMA appeals. So stay tuned for that IRMA appeal information here in a little bit. But for most of us, once we make this transition into Medicare, we have our red, white, and blue card. For most of us, we can opt for really 2 different pathways or routes into Medicare. Some of you may have an alternative pathway with a retiree package. They are far and few between. Like, I don't see many retirement packages these days, and the ones I do see, 80 or 90% of the time, I would recommend going private, meaning moving fully into a supplement and a drug plan, versus lingering on those retiree packages. Most retiree packages that I do come across are all selling a Medicare Advantage retirement package. And anyone who wants to get off those retirement packages that I'm coming across now are going over to that supplement to avoid the hiccups and hurdles and restrictiveness of the Advantage product. For most of us, we have these 2 pathways. And for most of my clients and most of YeskeBuie's clients, we are going to see you kind of favor the left side of the screen here. Most of you will go into what's called a Medicare supplement with a drug plan for the most comprehensive coverage. But let me take a step back, because everybody, no matter which pathway you select, everyone will pay that standard $202.90 for the red, white, and blue Part B portion of Medicare, plus any IRMA. So that's kind of a fixed cost under Medicare, regardless of the route you take. So here, if you're telling me and my team, I want great coverage, I don't want any pre-authorization, I don't want network restrictions, like I just don't want managed care, then this Medicare with the supplement and a standalone drug plan is going to give you the most optimal level of coverage you can get as you come off the group plans or turn 65. So here, when you're walking around with Medicare, your red, white, and blue card, You'll add a Medigap, also known as Medicare Supplement Plan. This is like your Plan F. If you're older, you know, you're what, 72 or older, you probably have a Plan F. You're grandfathered. Right now, if you're turning 65 or recently moved into Medicare, you have a Plan G or a Plan N. There's also high deductible Gs that you can look at. So all of these work in the same fashion. They allow you to go nationwide to any doctor that takes Medicare. You show your Medicare card, the provider bills Medicare. Medicare turns around and submits the residual, that 80-20, Medicare pays 80, the 20% is going to your supplement. The 1,700 per 60-day hospital occurrence is going to your supplement. So if you opt for what's called a Plan G and you get hit by, you know, the dump truck and you're in the hospital, you have, you know, outrageous medical bills, your only exposure here under Medicare and the Supplement G combination for all Medicare approved claims with any Medicare approved doctor nationwide is this very nominal $283 Part B deductible. After that, Medicare and your Supplement G pays 100%. So I would say the G policy is the most popular. I don't care if you're going with Blue Shield of California or Anthem or United Healthcare, AARP, or Aetna or Mutual. It doesn't matter. They're all identical in that they will pay 100% after Medicare pays, except for that 283 deductible. Okay. You're not going to get a ton of like bills in the mail. You'll just see that 283 is what's owed. And then once you pay that, you're getting Medicare summary notices of here's what Medicare paid, here's what your supplement paid. The rest is history. So it's headache-free insurance. You're not dealing with the push-pull and advocacy that's needed with the Medicare Advantage plans. In addition to picking out a supplement, and we'll help you do that. Again, we get all of these contracts with national carriers. We're paid about the same whether you're going ARP or Anthem or Blue Shield. Like, we just don't care. But I highly recommend reviewing your coverage each year, especially around the supplements. Supplements like every few years. If you're older and you haven't reviewed your supplement, highly recommend to do that. Usually we save, you know, $1,200 for a couple to like $2,400 for a couple. The carriers want you to set it and forget it. Okay, because they make money, they jack up the rates and hope nobody ever questions it. Our job is to help you just stay in competitively priced coverage and make sure you're not getting burned by the insurance company. The drug plan, so you have Medicare in your supplement or Medigap plan. You have a G or an N. N is very comparable. You'll have the 283 deductible and then $20 copays for provider visits and $50 copays for ER. And there's what's called Part B excess charge exposure under Part Plan N supplement. So what that means in a nutshell, more in the weeds here, but if you go to a doctor that accepts Medicare, they opt into the Medicare program, they can bill you the Medicare rate if they accept assignment, or if they're a non-assigned Medicare provider, they can balance bill you up to 15% above the Medicare allowed rate. Your Plan G covers that balance bill exposure if you go to a Medicare non-assigned provider. If you are going to a Medicare non-assigned provider and you see that 15% excess fee or balance bill, your Plan N will not protect you. They'll require you to pay that, and you'll get an invoice for that exposure. So G and N are very similar, and for like $20 or $30 premium difference, most clients go G for just the less headache, the less exposure, and just more comprehensive coverage. But some clients are sensitive to that difference between G and N, and they want to save $300 or $400. They'll go with Plan N. There's also a high deductible. I'll show you this chart here. So essentially how a high deductible plan works is you get all of the bang of the G product, except you have to pay roughly the first $2,900 for the year. in exposure. So if you're in and out of the hospital, you're, getting the MRI, you're coming out of pocket the first 2,900. Once you come out of pocket 2,900, then Medicare and your high deductible G pays 100%. So I don't write a whole lot of high deductible G when I look at the entire country, because there's many states that require underwriting to go from high deductible G to an N to a G, regular G. So nobody wants to get stuck in that high deductible G. And again, we kind of go back to the bigger picture. What's more important? Great coverage at a little bit higher price point, or saving, $400 and dealing with bills and making sure nobody's billing you or overbilling you. How neurotic do you want to get? And so I'm happy to show you the rates. My team will show you the rates for any of these products. But again, our goal is kind of to weed out what's the most important thing, what matters most to you. Is it price, or is it headache-free living? So no right answer there. In addition to picking out a supplement and helping you shop that, there's also this prescription drug market, also called Part D, standalone Part D. If you're on no meds, usually we match you with the cheapest drug plan so that you avoid what's called a late enrollment Part D penalty. If you're on 15 medications, you make our lives much harder, but we will shop the drug options and pair you with a drug plan that matches your specific prescriptions and keep those on the formulary. All of your medications that you are filling throughout the year will go towards this bucket. And once the bucket is filled with $2,100 in your drug deductible, your drug copays on your expensive meds, once all of those meet $2,100, then your standalone drug plan comes in and pays 100% for the rest of the year on covered formulary Part D prescriptions. So where we are seeing a huge shift in this market, there's a few things happening. Trump RX came out. Good RX is more popular than ever. Mark Cuban, if you're a Shark Tank fan, has his own online platform where you can shop drugs. GLP-1 Bridge just came out for weight loss, GLP-1 access. All of these fall outside of the Part D program. So if you're going out to cherry pick my $50 copay here, my $100 copay here, none of those are going to the Part D $2,100 bucket that gives you 100% coverage on those medications after the fact. So take that as and remember it, because you can save money over here, but in the long term, you may actually end up spending more because you're not chipping away at that 2,100. Food for thought. Another change that's happening is all of these drug plans across the country are kind of kicking the broker out. So we are losing access to simple enrollment, to servicing drug plans easily, to being motivated to shop these drug plans every year for consumers, because we, independent brokers, are no longer compensated for this level of work. So there is just a shift happening, and I'm planting the seed early. Lauren, we should probably sidebar this, but there is a shift happening where I am predicting, forecasting a need for kind of concierge drug consulting, where, hey, nobody wants to touch your drug plan once you're already on Medicare. Nobody wants to go into the weeds and spend an hour or two with you on the phone call to explain pre-authorization. The consumer doesn't want to sit on 1-800-HUMANA for 3 hours getting bounced around with brand new service reps. So I really see there will be this concierge need, and we're already kind of creating it as a alternative pipeline in our agency, because again, we're free service, but this Part D program is evolving as we speak, and it's all evolving. I'm going to skip a slide here. Based on this Inflation Reduction Act that was passed in 2022, that it took effect in 2025 and 2026. So that $2,100 drug cap that I keep referencing is brand new regulation. Prior to that, if you've been on Medicare or had parents on expensive meds on Medicare, everybody had this old school notion of the donut hole and Part D exposure. And I spent 20 minutes on these webinars explaining it. where you didn't have a cap on your worst case drug exposure. If you were taking a $20,000 chemo drug that filled through a specialty pharmacy, you were paying the first 8 grand and then 5% on that $20,000 med each month. So there was no cap. So it was a huge gap in Medicare coverage and exposure for consumers. Well, now we have this $2,100 cap, which is amazing regulation. But on the flip side, the consumer is seeing less choice. There's fewer drug plans out there than there, about half exist today that were available 2 years ago. What we are also seeing is the carriers hemorrhage. You saw everybody's stock decrease substantially in the last 2 years. UHC, Centene, Elevance, if you've been in the market. So the carriers are saying, we don't want to touch this market. We don't want enrollments. So they've cut brokers out of the equation because that's where a lot of enrollments happen. The clients, you all have fewer access points to advocacy and fewer options that you can shop from, all stemming from this $2,100 cap, which is a huge win for people on expensive meds. But the whiplash is happening, and it's happening right now. So these drug plans are reacting. In addition to that, the supplements that have their hands in the drug plan markets and the advantage plan markets, the supplement carriers are also saying, oh my gosh, we're reacting too. We're going to increase the premiums on our supplements to offset these changes because of regulation, the post-COVID high utilization era. More people are using claims, people are aging faster, medical, inflation is going up. So these supplements, on average, we have seen increase between 10 and upwards of 30% in the last 12 months in almost every zip code. So if you have been impacted by the supplement rate increase, know that it's happening everywhere. It's not just you. So as we shop these, know that, hey, we can save you a couple of $1,000s in savings, but know that there's no protection that won't keep your rate from increasing at that high rate each year. And then on the other side, if you don't want to supplement in drug plan, that advantage market is also available to you. That's the alternative pathway. And it too is kind of absorbing this new exposure that it has with this Inflation Reduction Act and $2,100 cap. So here, if you're a client that's like, I don't want to pay for my healthcare. I don't use healthcare. I'm in Mexico half the year. I'll get my dental and my medical services there. This Medicare Advantage product can be very attractive, but there are many disadvantages. And my goal is to just showcase those disadvantages because the advantages are easy. It's cheap. Usually you're paying $0 to $50 a month in premium for the Advantage plan. You get sometimes dental and vision baked in there for free. You get your drug plan for free. It also has the $2,100 cap. If you go to see a primary care specialist once or twice a year, you're only out of pocket is, $80, and you got free dental, drug, and vision for the year. On the flip side, if you start using care routinely, you realize how tight these HMO and networks can be. You also realize or need to realize that the networks are not guaranteed year after year. Last year we saw about 20 major hospital systems across the country get in contract disputes with the insurance carriers. So Mayo Clinic went head-to-head with Humana and UHC. Johns Hopkins on the East Coast had toe-to-toe for contract dispute. And about half found resolution. The other half said, we're splitting ways. You're no longer an in-network provider as of August 1st. What? The patient was left holding, the bag and saying, hey, I don't have access to my doctor anymore. So there's no guarantee to access to providers for the full year or next year. Also, the plan designs, if you go into an Advantage plan because you're healthy and you like the free perks, there's no guarantee that those plan designs are stable year after year. And what we are seeing right now with this Inflation Reduction Act evolve and change the entire playing field is the extra perks that we've seen that were like crazy robust over the last decade. In the last 24 months, we've seen those almost stripped. Like, hey, we're shedding broker commissions, we're shedding extra perks, all those bells and whistles that enticed enrollment for a decade. We want to disincentivize enrollment. And so we see plan exits. So in the fall, you need to be looking at your mail to make sure that your plan is not terminating for January 1 and you're not uninsured. We also need to make sure that you're choosing a right plan for right now, but be aware that that plan design can change at a later date and you're at the whim of the insurance carrier and their decision making. And then the last negative here is just that push pull that you get from your provider who's saying you should go get this, and your managed care HMO or PPO Medicare Advantage plan saying, nah, we don't think you need that. Let's try these alternatives because they're cheaper for us and we're a for-profit entity. So there is another party who's mingling with your care. It's not you and your provider. It's you, your provider, and then, your parent, which is the insurance carrier who's saying yes or no. So again, it's cheap, but there are very many disadvantages that we all need to be aware of because, again, the marketing around these advantage plans is heavy. You're turning 65, you're getting solicited, you're getting phone calls left and right from brokers saying, 1-800 telemarketers. Who knows who's got your number? But I see this all the time. So just be savvy, watch this, go see other Medicare 101 events, educate yourself in advance of this transition so you know exactly what you're getting when you do sign up. And I lied. The last negative to the Advantage plan is that if you choose this cheap route because you're healthy now and you say, Margo, I'll change to the supplement, the more robust route in a decade when I need it. Well, in most states, California included, in most states, all but 4, it's like Massachusetts, Connecticut, New York, and I want to say Maine, all of those other states, the 46 other states, require medical underwriting to go from Medicare Advantage over to the medical supplement, Medicare supplement, Medigap plan. So if you're changing your Medicare Advantage plan 6 years after you move into Medicare and later want to pick up a supplement, that supplement's going to say, well, how's your health? What's your health risk? Are you on tramadol? Do you need PT? Are you on 3 blood pressure medications? Sorry, you're automatically denied. And now you're left shopping and scrambling in this Advantage plan market. Whereas the flip side is not true. You can go Medicare supplement day 1, no underwriting, no pre-existing because you're new to Medicare Part B, whether you're coming off that large group plan or you have to go Medicare at 65, you have this special enrollment period to pick your supplement with no underwriting, no health questions. You're guaranteed issue. You're enrolled. And then later, if you say my finances have changed, I need to adjust, you can downshift to a Medicare Advantage plan, that cheaper route, very easily. But the reverse is not true. Whew, okay.
And Margo, if I can maybe chime in with a question and you can answer where you feel it's appropriate on the supplement plans. Just a question that came in about coverage while you are outside of the US. So you mentioned somebody in Mexico. We had a question about if you are traveling abroad, what does Medicare cover or not cover in that case?
Okay, great question. So your supplement G and your supplement N will cover, so basically you have a $250 foreign emergency room deductible. It's not shown here, but Medicare won't touch you. Your supplement will say you're responsible for the first $250 foreign emergency bill, and then we'll cover 80% of that emergency bill up to a lifetime maximum of $50,000. Okay, so most clients when they're traveling, and this is an indemnity, so you have to come out of pocket and then you submit the exposure or the receipt to your supplement carrier. So most clients will opt for like a simple travel health policy that runs like 100 or 200 for a week-long trip. And now that is like real-time insurance. So you show your insurance card, they're going to pay on the spot. Like you don't have to do any of this claim submission. And then usually those travel policies also include like evacuation if you need a helicopter or an air vac. It goes above and beyond what Medicare covers on the supplement product. But the N and the G it does have the 80% up to $50,000 lifetime benefit.
Great,
But
thank you.
Medicare won't cover you.
Okay, great.
And the Medicare Advantage product, it will cover emergency room visits worldwide at in-network rates. But again, anything outside of an ER visit is going to be beyond Medicare and the supplement. You need travel health for that.
And one more question on, sorry, one slide back that you were just on there with this one. If someone delays their original Medicare enrollment because they're on a large employer plan past 65, is it still the no underwriting when they first sign up for original Medicare and supplement and Part D?
Correct. Yeah. So you're delaying Medicare B, stay on the group, and when you're ready to retire or voluntarily come off that group, you are enrolling in Part B and you become new to Medicare and you get your supplement and drug plan with no underwriting. Correct.
Thank you. All right, that's all we got for now.
All right. Hopefully you weren't holding your breath for Irma. But here it is. So essentially, let's go to the very bottom, the bottom row here. So if you are a single filer making above 500 grand, or a joint filing couple making above 750,000, Medicare is going to be very expensive for you. And what Medicare is looking at, if you're moving into Medicare in 2026, let's say October of this year, you're going to enroll in Medicare. Well, IRS is going to send Medicare and Social Security your tax info from 2024. So they're going to look and you're going to see a letter from Medicare saying, hey, we received your IRS 2024 tax return and your modified AGI was above 500,000 as a single filer. Therefore, instead of paying $202.90 per month, we're going to slap on an IRMA surcharge for Part B and a $91 drug surcharge for whatever drug plan you get, whether it's a standalone or you're going that Medicare Advantage pathway. We're going to slap on IRMA in 2 places. And now your total just to get in the door with Medicare without any conversation around supplement and drug plan premium is $780 a month. And if you have a husband and wife who had a 2024 modified AGI that was above 750, well, then each of you, once you're on Medicare, each of you will pay $780. That is either drafted automatically from your Social Security check, or you're setting up like an auto pay out of a credit card or a checking account, or you're old school writing a check every month or every quarter. So Medicare is always on a 2-year delay. And so if you're moving into Medicare in 2026, 2024 is being funneled to Social Security and Medicare to set that 2026 premium. And then late in the fall, you're going to get a letter saying, hey, this is IRS and Medicare communicating again. We see your 2027 IRMA should be this based on that 2025 tax return. So it's constantly updated automatically by IRS and Social Security. You don't have to do anything. What Medicare doesn't know is if you or your spouse has had a life event, a qualifying life event, like work stoppage, you retired, you reduced your work hours, you went full-time to part-time, you switched jobs and you're working less. We can tell Medicare that, hey, I've had a life event. Don't use my 2024 tax return from 2 years ago to set my 2026 premiums. I retired in 2025 and my income is now, 110,000 or 150,000, not 500,000. Use this lower anticipated 2026 income, modified AGI figure, because of my retirement. Use my lower anticipated figure, not my old dated information from 2024. So we can appeal Medicare and have them use your anticipated 2026 income to set your 2026 premiums. We would do that again. We would file another appeal in 2027 to say, hey, Medicare, I retired in 25. You may still see a high earning status in 2025 because I worked 3/4 of the year. Use my anticipated 2027 retirement income. Okay. And that's where we pull in a lot of advisors, is to help kind of estimate that anticipated figure with conversions. This is your wheelhouse, Lauren. Everything that would increase a modified AGI figure should be considered for that anticipated estimate.
Yeah. Yeah, it's a really good point, Margo. It's something that we take into account when we're doing our end of year tax planning. If we're looking at Roth conversions for a client in retirement, for example, that's one of our triggers is, hey, is this going to trigger a IRMA at all or a higher IRMA? Just to think through, we kind of think of that as an additional tax on that Roth conversion because it'll be paid 2 years from now. Margo, I have one question and one statement that comes up a lot for us. The question just being, what if the client gets it wrong in this SSA 44 form? They say, I think my income's going to be 150, but let's say they get another job later in the year that's much higher paying, or some bonus that they get through the lower paying job and they end up higher. What actually happens there?
Yeah, so if you underestimate your SSA 44 appeal, so we submit, we say, Medicare, I stopped working, use my 26 estimated, not my 24, and you lowball it, okay, and you get it reduced and you're paying no IRMA versus 300 in IRMA. Well, Medicare does play catch up, and they'll fact check when you actually file your 2026 return. They'll match, and they'll data match with what was put on that SSA 44 form. And if you made much more in 26 than what you lowballed, they'll make you pay back the difference in true IRMA that should have been paid. So if you say, hey, I'm making 500 grand in 2024, I retired, I'm now making 90 grand, and that's what you use on your SSA 44 form, you've paid no IRMA for 2026. When they match and you actually came in at 200 grand, 210 grand, you should have been paying, close to $550 a month in IRMA times 12 months or however many months you got the IRMA appeal reduced. So they'll send you an invoice for the difference once they true up the figure versus the anticipated appeal form. So there's no penalty or tax or percentage that is added on top of that for being wrong. It's just they'll true up the amount. On the flip side, if you're like, ooh, I think I might be 110, but I could be 90, I'll just put on 110,000. And you pay this IRMA for the full year. Well, they won't go back 2 years later and say, hey, you overestimated. We're going to send you an invoice for, the 120 times or 100 times 1,200 bucks. They will not credit you for overpayment of IRMA. So be aggressive if you are on one of these thresholds, or you think, because being $1 above kicks you into the higher bracket. So be wise. This is where, again, most CPAs and advisors do have this on their radar, but always take a more aggressive approach so that I'd rather have my money in my pocket earning interest than, be out that money. So that's the recommendation there, is get a little aggressive. You're not avoiding this. You're just, being wise. Mm-hmm. And like you said, there's a difference between avoiding IRMA. Sometimes we can't avoid it. We can't appeal it, but just being aware that it's on your radar. It's coming down the pipeline in 2 years because of what we're doing right now is half the battle. It's like taxes. Sometimes you can't avoid it.
Yeah. Yeah. And then one that just comes up a lot with clients, just to confirm, that something like selling your home and having a large capital gain is not something you can file this SSA 44 appeal for.
No, correct. Unless it's like a hurricane,
Mm-hmm. Okay.
Yeah. So no, the home sales, you got to write it out for a year and then usually you settle back down. So good question. But this is, if we are strategizing like an exit agreement, definitely this is something that comes up. Is it smart to take a lump sum up front versus like a 5-year buyout where you have 5 years of IRMA, high earning status, versus 1 year of IRMA? Again, it's one piece of the larger picture that usually gets considered. So, okay, so anybody who is already on Medicare, October through December is when you can shop your drug coverage, or your Medicare Advantage plan. If you're also on a Medicare Advantage plan, you have kind of a one-time oopsie if you get in the wrong Advantage plan in January, February, and March to make a one-time change to a new Advantage product. The supplements, we can shop those supplements year round if you can pass underwriting. And then in California, we have the birthday rule. In about 14 or 15 other states, we have anniversary or birthday rules that allow you to shop plan to plan on your birthday with no underwriting. The carriers prefer underwritten business because they actually know what they're getting. They can select the risk pool. So you'll see a little bit more competitive price with heavily underwritten products than, guaranteed issue, everybody's taking everything, because the carriers can actually rate their risk. With that being said, there is protection in many states, roughly 15 consumer protection laws that allow you to never be stuck in your supplement. And then if you have a younger spouse, the ACA markets have changed a little bit. That would be a whole nother webinar, but the ACA markets, that November 1st, essentially through December 15th for most states. This upcoming year, it'll be like November through December for most states. That January and February extension and the big, beautiful bill that we saw, what was it, last year pass, it is kind of putting more restriction on state exchanges like California, like Virginia, like Maryland, that had this robust enrollment timeframe all the way into February. So now the state exchanges are being kind of honed in on their enrollment period. And really, we're going to focus on that November, December timeframe for ACA changes, unless you have a qualifying life event like a divorce, or you're coming off group because you're retiring at 60. You get fired, you're terminated, you're let go, whatever, downsize, whatever it is, you have a special election window that rolls, 60 days around the qualifying event. All right, GLP-1, I think I have 2 minutes to explain this. That's all I need. So this just got announced. I just typed this up. So if there's errors in this, it was about 10 minutes before the presentation. So here, if you are diagnosed with diabetes or sleep apnea and you're filling your GLP-1, well, that's all going to funnel under your Part D drug benefit once you move into Medicare. And you're chipping away at that $2,100 bucket of exposure. Once you hit $2,100, your Wegovy or, Zepbound is covered at 100%. Your Ozempic's covered at 100%. However, if you go to the doctor and the doctor's like, hey, your BMI is high, you're on Medicare, and you we need weight loss. Well, you're triggered into this new GLP-1 bridge program. Doctor submits the prescription over to pharmacist, flagged for GLP-1 bridge. Pharmacist runs it through the GLP-1 bridge Medicare program. And now, once you're pre-authorized in that GLP-1 bridge program, your GLP-1 for weight loss becomes a $50 copay. So many people over the last 4 or 5 years, as these GLP-1s were getting picked up by drug plans, many people went to the doctor and they're like, figure out how I have sleep apnea so I can get my GLP-1 covered and satisfied at that $2,100 benchmark. Well, now people are going to be like, bah, I don't have sleep apnea. I have weight loss issues. I want to pay $50, $600 for the year for my GLP-1, not $2,100 for my sleep apnea GLP-1 needs. So I feel like the providers are going to be kind of stuck with the paperwork here, and the pharmacy, because the pharmacy, if they're filling GLP-1 at a $50 copay, I'm not, again, that's a little outside of my privy, but how are they getting compensated by the government to make them whole, the pharmacy? So it'll be really interesting to see which pharmacies actually play ball with this GLP-1. Are they required? Are they mandated? There's a lot of unknown here, and we're going to see just the ripple effects of this GLP-1 program. Will it make Medicare premiums as a whole increase? Is Medicare funding the GLP-1 bridge program? So many questions I have here. I only have limited answers, but this is all coming out as we speak. It's going live July 1. And it'll be interesting to see, again, the long-term effects of this. From a consumer, it's great if you can get flagged as weight loss and removed from that diabetes or sleep apnea need, but it's still available if you do have diabetes or sleep apnea. It's just going to be a little bit more expensive going that route, which is wild. Anyway, so this is the GLP-1 Bridge program. You can read more on CMS. If you're a client of ours right now, we're going to be sending out a newsletter probably in mid-July with info on this, TrumpRx, GoodRx, Smart Cuban, just again, that consultative nature of this drug market that is evolving with all the different players coming into Medicare and drug vendors. So again, start your conversations early. Don't wait until the last minute, especially if you have younger kids or a younger spouse who's impacted by this turning 65 event. We are here to help Lauren and her team. We're here to help you guys. My goal, my team's goal that I've like drilled into them is education, support, confidence. And then if the transaction is necessary, we help you through that enrollment. But first and foremost, is Medicare required? What's going on? What's your unique circumstance? Let's use those facts to create a strategy to help you understand next steps and go from there. So again, this is recorded. It looks like it's live right now. I'm not sure if it's being fed to Facebook or LinkedIn, hopefully, but yeah, so we're here to support you guys. Let me know if you have any questions after the fact. Hopefully the wine's kicking in now and you can have a great mellow rest of the day.
Thank you so much, Margo. I really appreciate it as always. I'm sure this time next year when we have you back, you'll have updates on the GLP-1 bridge program and whatever other changes come up between now and then, since it seems to be nearly constant. But we just really appreciate your knowledge and expertise and educational approach. And, obviously your contact information is here on the screen, but if anyone has questions or needs contact information, feel free to reach out to us. We can connect you with Margo and her really awesome team and at whatever transition it is, Medicare, ACA, deciding what to do with COBRA or not COBRA and all of those pieces. So they're really a fantastic resource. And again, thank you so much, Margo. Really appreciate your time today. And we hope you all have a wonderful rest of your day. Thanks so much for joining us.
Thanks.
Bye.
Bye-bye.